Hello, welcome back to the session. I'd like to thank the FUS Foundation for putting this together. It's been a really great opportunity to discuss some important issues. We're going to talk about in this short session on sonication parameters. And the panel we have today is starting with Kullervo Hynynen at Sunnybrook in Canada, Elisa Konofagou from Columbia University, and Francesco Prada from the Institute of Neurology Besta in Spain. Sorry if I pronounced that incorrectly. So I think I would just get started by maybe going around the panel and talking about what are the typical sonication parameters that you use, and maybe how you came upon those parameters. Maybe I'll start with Elisa.
Yes, thank you, Nathan. It's a pleasure to be here. So we changed the pressure typically to get higher permeability, and we found that at least in mice between 0.3 and 0.6 megapascals, at 0.45 seems to be our sweet spot for the pressure. And that also has to do with the microbubble size that we have also worked with, but also more recently with DEFINITY. We seem to be getting enough of the permeability increase and at the same time the safety that we need for the inertial cavitation to stay low while we have enough of the opening region. So that's, for us, is the pressure is actually driving most of what we do.
Right. Kullervo?
So we use 10 millisecond pulses once a second roughly, and we ramp up the power until we see subharmonic emissions, and then we scale back to 50%. So that's our typical pulsing sequence, although we have tried like single cycles and others and seem to work, but the most experience we have with 10 millisecond pulses, and we typically sonicate about 2 minutes once a second pulse. But that's because of the bolus kinetics of the DEFINITY that we're using, but it could potentially go longer and probably have to consider it in the future.
All right. And Francesco.
Hi everybody, it's great to be here. So here in Milan, we are going to start a clinical trial. So we're going to use the parameters that have been discussed in the previous session, and of course it's going to be past sequences. And I also started a lab, and we are working with in vitro guinea pig brain using and we're start using a planar wave with sequences similar to those used by the Cartera group, again with past sequences and a PRF of 1 megahertz.
So sorry, I put you in Spain instead of Milan. My apologies.
Yeah.
Sorry about that.
I wish. I mean, it would be bad, maybe.
One of the questions that, so one of the things in reviewing this, in preparing for this, was that the BBB opening seems to be possible with almost any parameter. And, people have gone at really low frequencies, very high frequencies, single pulses, short sonications, long sonications. And I don't think there's a consensus on, that there are optimal parameters. I just wonder if I get your opinion on if you think that there are optimal parameters, and if there is some way to, or if you were to define, how do we figure out what an optimal parameter is for ultrasound? Because the parameter space is quite large. Maybe I'll start with Kullervo on this. You've done a lot of work looking at parameters back when we were Brigham and in Toronto. Do you have any thoughts about, have we found the optimal parameters, or do we still have more work to do?
So Nathan, very good presentation that you gave in the video. Good summary. And I think you highlighted the question that we have is, do you want to maximize the drug delivery and minimize damage? And so, so do you have those two parameters you have to work with? And I think we have currently parameters that seem to work. Are they optimal? I don't know, and most likely are not. And it probably depends on the bubble that you use. We are discovering surprising effects of different bubbles. Even different cell materials have different effects. And it seems to be that the effects on the tissue are different depending on the bubble, and not necessarily that how much is going through. So I would say no, we don't know optimal parameters, and it depends also on the drug that you're trying to put into the brain. Are you talking about cells, or are you going to talk about antibodies or chemotherapies that probably will be optimal for each molecule that they're trying to put in. But right now, I think we are in an area where we can test and need to show that there is clinical benefit. And I think we can do that with the current parameters.
Thank you. Elisa, do you have any thoughts on parameters? What are best?
Yeah. Yeah, I mean, I agree with Kullervo. I mean, it depends what you're delivering. I think if you can't go blind with the parameters, regardless of what you're after. I mean, whether you're delivering gadolinium, which of course doesn't treat anything, but it does show you the area that the gadolinium actually diffuses, all the way to gene delivery vectors, for example, that can be on the order of tens of nanometers, if not hundreds of nanometers. So you have to be cognizant of how big you want the actual opening, not volume, but the size, for the vessel for the actual drugs to go through. So we published on the pressure allows you to have larger molecules. So if you go from 0.3, obviously, or 0.2, whatever your threshold is, depending on the frequency, and we know that the threshold of the opening drops with the frequency. So, so if you're going right at the threshold of the opening, you can get gadolinium in, and maybe some other BACE inhibitors or gamma inhibitors that are used for Alzheimer's disease, so small molecules, but not necessarily proteins or antibodies. So there you have to either increase the pressure or on the duty cycle, the pulse length, to open more the size itself. And for gene delivery vectors, obviously, it is even more. I mean, the pressure definitely drives that, and also the pulse length. So the other thing that we've seen is also co-injection of the bubbles with the drug. So that definitely makes things more effective and efficient, because you have streaming or radiation force that is helping during the active bubble, oscillation that will increase penetration. And the final thing that we also have reported is the bubble size and the shell carbon length. So that will actually inform the type of activity that the bubble undergoes. So we found that 4 to 5 micron bubbles are more efficient than the 1 to 2 micron bubbles, for example. So you could think about what drug you want to deliver, and then pick the right pulse sequence and the right bubble, and then potentially co-inject.
Thank you. Francesco, do you have any thoughts?
Yes, I agree that I want to share with you a recent experience. So we've been using, we've been performing blood-brain barrier opening with a diagnostic probe, doing contrast-enhanced ultrasound imaging and BBB opening at the same time. And when we designed the way to deliver the pulses and the sonication, we chose between 2 ranges, one with long burst of pulses and a longer period between pulses, and then another one where the pulses were regular. I apologize, I'm a neurosurgeon, so I'm not a really technical guy, but I hope this, I give you an idea. And actually what we found in this model in vitro is that the BBB was consistently opened in both cases. And the frequency was pretty high because we were using probe with a center frequency of 4.5 megahertz. So yeah, I agree. I think what we observed also is that, at least with the imaging, is that the bubble disappears after the burst. Not completely, but it is important to wait between the train of pulses to the area to be filled again by bubbles, of course. And so.
Right, thank you. And you gave us a very nice presentation on microbubble administration, and talked about some of this work. And from our clinical experience, just for some practical reasons, we tend to now use an infusion of microbubbles, where we inject the microbubbles into saline and have it as just a drip. And we're at a much lower concentration typically right now, again, largely due to practical reasons and regulatory issues, than we're able to get in animal studies. I guess I'll pose a question to the group about, do we think that the infusion is better or worse than bolus? And do we need to go back and rethink some of these clinical or preclinical studies we had? A lot of them use very high concentrations of microbubbles that are not going to be possible in clinic, at least in the short term. Do we need to go back and look at some of the data again? Kullervo, do you have any thoughts on infusion versus bolus and dose of microbubbles?
Yeah, no. So yeah, so we have done some work with. So typically we use the clinical imaging dose, but before going to clinic, we dropped it to 1/5. We did a study where we can still see effective blood-brain barrier opening, and that seemed to work well. And then of course you come a limit to how many doses you can inject. So the infusion makes perfect sense where if you are limited by the speed of the sonication, if you have to sonicate large volumes, it gives you much more efficient. Like the video presentation gave a good study, so I like that. So I definitely agree that that's the way to do, and it gives you more consistent bubble concentrations throughout the treatment. And I absolutely agree that the drug should be there same time than you're sonicating. When we try to get larger particles in or cells, we cannot get them in unless they are there during the sonication. So that's a sometimes problem with chemotherapy, because sometimes we cannot do that. So because of side effects, but if you can do it, it should be simultaneous. But yeah, I would say infusion is the way to go.
Okay. Elisa, have you looked at infusion versus bolus?
No, it's starting to, and learning from you guys. We mainly do bolus, so borrowing mainly what happens with diagnostic contrast imaging. I agree with the dose. I think we should use clinical dose, approved clinical dose for now. We haven't seen that there's a big difference. I mean, obviously you get less of the efficiency with fewer bubbles, but you can definitely get opening and significant opening. But I guess taking advantage of every bubble and not wasting bubbles. And then again, what Francesco said about the replenishment, taking that into account, and potentially also using the heart rate of the subject as a guideline of how fast these bubbles are coming in. I think it would be definitely a smarter way going forward.
Yeah, Francesco, do you have anything to add?
Yeah, no, I totally agree with the fact that for BBB, infusion is probably better because you have a more steady level of microbubble throughout the procedure, and also it has been showed by imaging studies, you can have a longer period of with a stable amount of microbubble. I do a lot of intraoperative imaging with microbubble guidance. And I have to say that the higher discrimination between tissues is during the peak phase. So when you inject the bubble with a bolus. Whereas when you have a washout, when you have the washout, the differences between areas decrease, and it's the same with the infusion. So maybe for other microbubble mediated therapies like microbubble enhanced ablation, it's probably better to perform boluses and use the peak phase to sonicate during the peak phase in order to take advantage of these differences.
All right, thank you. One of the questions I have, and this is just a curiosity on my point, is when we've switched over to this infusion, so there's, in the clinic, we use a saline drip. And, the picture I have in my head of this is that maybe the larger bubbles are not getting administered. And Elisa, your group has shown that, you get better opening with the, larger bubbles. And in preclinical studies, and at least in rodents, it's hard to do a drip. So you would be using an infusion pump. Do you think that, I just don't know the answer to this. Do you think there's any difference in how we do this infusion? And should we use a pump, or should we, hang the bag, or?
Oh my goodness, I'm not the right person for that. Okay. But I would say, yeah. I think we have at some point to move on from the diagnostic bubble to what we can design as the therapeutic bubble, right? So what is the one the bubble that's the best for blood-brain barrier? So I think right now we're borrowing from the diagnostic imaging world. But yeah, what we found is that, if the size or the carbon length of the shell or the dose or all that stuff may need to be optimized for what we want to do. Now, of course, the infusion drip versus pump, that's not my expertise, but I think there's something there also to adjust if we change the bubble in any way.
Francesco, when you do the your imaging, do you use a drip or are you using an infusion pump?
Actually, when we do the imaging, we use the injector provided by the company. What makes
the mixing
really
injector?
And no, and then the anesthesiologist inject it as a bolus.
Okay.
But really, what makes a difference is how and who prepares the solution, and we can really see a difference between different operators. So probably the best one to prepare the vial for injection, since you have to shake them a lot, is a barman. But for the infusion, I have to say we are using in vitro, in our system in vitro in the lab, we are using a pump which is mounted on a rotatory table. But we see that we use the same vial for sometimes 2 hours, because we do imaging as well, and we see a decrease in the quality of the imaging during this the infusion, probably because some bubbles, they sediment in the syringe or they break up. So
thank you. So in the last 1 or 2 minutes, I don't know if anyone has any final comments to make about parameters or microbubble administration. And I'll start with Kullervo, if you.
Yeah, no, it's a complex. I think we don't know too much about the bubbles yet. So it's interesting that there are now studies showing nanobubbles being very effective and with minimal damage or no damage and huge blood-brain barrier penetration. So I mean, I think that the jury is still out what should be used, but yeah, and how to use a drip or infusion in animals works well with the pump, but in MR scanner, the patient usually is the back dripping of the bubbles.
Elisa?
Yeah, I mean, we have a lot. I mean, going back to your optimization question, Nathan, I think of the ultrasound part, I think the sequence, we're doing better than, figuring out the bubble specifics. So I think we're ready to move from the black box of whatever the vial is and be able to use both parameters in tandem to figure out the best combination.
Right. And Francesco?
I think, as has been said, there is a lot of variability, and I think the most variable issues are the bubbles. So probably it would be great to have a microbubble made precisely for BBB opening or for focused ultrasound treatment rather than using imaging microbubbles.
That's a great idea. So I think we're out of time, and I would like to thank the panelists for this very interesting talk on this very wide parameter space, and it seems like we still have some work to do. So thanks, everyone.
Thank you.